this very high dose of science that we received in the morning. I would like to welcome you all. And I would like to go back a little bit and start very basic to tell you, I see many of my young colleagues here who are starting refractive surgery. So I think the topic of choosing your patients, especially if you are still starting the refractive surgery journey, is very important. I know all the information that we had today are very up to date and useful, but let us review some of the basic principles. What are the patients that you should avoid? First, any patient with any general problem like autoimmune disease or uncontrolled diabetes, any immunosuppressive, and even in pregnancy, try to avoid doing any pregnant case until she. Why is that? Because the refraction changes, the response change, the hormonal change, the biomechanics of the cornea also change. So please avoid doing surgery in these cases. Locally, of course, it's very important to avoid any patient with any active disease. So if a patient has blepharitis, as was shown in a very nice picture, you have to treat him first. Don't underestimate the effect of any local problem on your final result. And when you are doing corneal refractive surgery, remember that the cornea is part of the eye, and the eye contains many other organs. So don't miss examining all parts of the eye together. Of course, keratoconus is a big challenge, and all the research now is how to predict the patients who are liable to develop post-refractive surgery ectasia. Dr. Mazin explained the corneal biomechanics, and it has opened a big horizon for us if we can detect those patients, because in many cases you do normal case, you abide by the rules, and unfortunately you may get later ectasia. Why is that? Because there are some inherent factors in the cornea that may develop in addition to some external factors like eye rubbing. So please try to avoid any suspicious case of corneal topography or corneal tomography, as we learned. Then the basics, age, whether to do it at 18 or 21, it's very important to have an evidence of stabilized refraction. Most of the patients stabilize at age 18, but some of them still develop. Why is that? Because you don't want a surprise, a post-operative surprise of residual myopia or the patient having regression. So please try to wait until you get an evidence of refractive stability. Okay? Of course, the only, and this is very important message, the only situation where we don't respect the age is the cases of marked anisometropia in children. In children, some of them have anisometropia. One of the eyes is very weak, while the other eye is normal or slightly weaker. We do refractive surgery in these patients not to get rid of the glasses or make them emmetrope, but to reduce the difference between both eyes so the patient can wear glasses, can do binocular vision, and can grow up normally until he reaches the age of 18 or 21. Then we can do him refractive surgery to get rid of the glasses. Motivation is very important, and my message to my young colleagues, don't oversell the procedure. If the patient comes to you, you have to make sure that he himself wants to have the surgery. Don't advise the surgery. You can tell him there are many options for, you can have glasses, you have contact lenses, and now we have refractive surgery. And then let him ask you. Don't tell him, I advise you to do refractive surgery. So please don't oversell the procedure. Have the patient be motivated. Why is that? Because the patient who is not, he would say, if he has any minor residual error, he will say, you promised me 100%, you promised me excellent result. So please, usually under promise and over deliver. Tell the patients, everybody who comes to you, you tell him, our aim is not 100. There is nothing 100%. Our aim is not to get rid of the glasses totally, but to help you do or manage your normal life without the dependence on glasses. But there are situations where you may need to use glasses, like driving at night or like watching TV. This is a very important message, and if the patient did not accept it, please don't do him. So this will be important. This is what I mean by realistic expectations. Patients who come to you think that refractive surgery is magic. You know, you can just treat him and correct any type of irregularities and any type of corneal problem. No, every patient, as we learned today from this vast investigation, should be treated individually, and every patient should have a certain percentage of success, depending on the nature, the biomechanics, the tomography, the everything that was mentioned in the morning. Again, the personality is very important, and my worst cases are the cases that I missed noticing the personality. Some patients are very meticulous, and they come to you with maybe 10 or 15 prescriptions. They want perfection. These patients, you have to be, as I mentioned, very cautious. These are the patients that you should try to discourage them. Why do you want surgery? You are doing fine with the glasses. Let him counter-attack, okay? Because some of the personalities, as I mentioned, they will give you troubles later on, okay? You notice this from his appearance, from his personality when he speaks to you, from the way he describes the refraction. Sometimes he said, oh, I went to many doctors, they didn't know how to do this. When he leaves you, he will say also bad things about you, okay? And the profession is also very important. Please try to avoid lawyers and engineers if possible. For lawyers, you know why. But for engineers, it's important to explain to them, because all engineers believe that 1 + 1 is 2. I tell them 1 + 1 is not always 2. Sometimes it's less, sometimes it's more, depending. We are dealing with a human tissue, and the human tissue has a healing power, and this healing power differs from one person to the other. You may get perfect results in most of the cases, but in some cases, you may get less results or even more results. So the profession is very important, and nowadays you come with a young chap who comes to you, he searched in the internet, he comes and said, I have -3 and I want to have smile. For this patient, I always tell him, please, you are not to choose your operation. It's the doctor who will examine you properly, honestly, and he will decide for you the best technique. It's not your job to treat. We may discuss the advantages and disadvantages, but at the end, it's the doctor who decides what's best for you. We heard about the history from Francesco, and it's important to follow the patients who has glasses to make sure that they have stable refraction. Patients who wear contact lenses, of course, they have to put off their contact lenses depending on the type. Rigid contact lenses may need weeks to be off of their rigid contact lenses, while soft contact lenses, usually 1 week is enough. We also discussed previous surgery, general medical history, any systemic or topical medications. Also, when the patient comes, it's very important for you to judge the attitude of the patient, the general appearance, the way he walks, the way he dresses, because this will give you an impression, as I mentioned, about his personality and about his reaction post-operatively. The eye is always, the cornea is part of an eye, and everything is important. For example, cases of enophthalmos. If you don't notice these cases of enophthalmos, you will have serious problems putting the speculum. Exophthalmos may be the reverse. Putting the speculum, the eye may pop up. So try to make sure that the appearance, the palpebral fissure is okay, the lids, they don't have any inflammation or any infection. Usually contact lens wearers may have GPC and they may give you problems really post-operatively if these rubs against the cornea post-operatively. And again, we've discussed the lacrimal system and the ocular surface and its effect. So that you have to deal with the patient as a whole eye exam, not just cornea. Okay? Examine the lenticular changes, because I have been, especially with old patients, if patient has slight lenticular changes, this may be the cause of post-operative regression, and these lenticular changes may progress, and the patient will claim that his vision deteriorated and he lost the effective vision. Also, the intraocular pressure. A big message I always mention. After refractive surgery, measurement of the intraocular pressure gives you false low intraocular pressure measurements. So if after refractive surgery the pressure is 15, no, it's in reality 18 or 19. Why is that? Because of the biomechanics, the changes in the biomechanics. As we learned, the cornea will not respond adequately. It will respond more, it becomes more viscous, and it will give you lower reading. So if your patient is glaucoma suspect or glaucoma, or he's using medications, you should warn him, and you should warn his doctor, because many of our colleagues in glaucoma may miss this part. The pupil was mentioned by Francesco. It's very important. Why is that? Because in many cases the patients get night vision problems. At night or dark, the pupil dilates, so the periphery of the cornea that was not operated comes into action. In reality, the most important is the edge or the margin of ablation. If the ablation profile, as we will learn in a while, if the ablation profile deceives the epithelium and becomes very smooth, we call it the transition zone or connection zone, then the patient will not, even if the pupil dilates, he will not appreciate it. But if there is sharp transition or distinction between the treated and non-treated area, then the pupil diameter will make a great effect if the ablation is less than the scotopic vision. Refraction, it looks simple, but in reality, as they say, garbage in, garbage out. If you put the wrong refraction, you will get bad results. So please pay attention on the refraction. Don't depend on the autorefractometer's printout or the patient glasses. You have to spend more time doing the refraction and doing subjective refraction and doing true evaluation of the patient. You have to have a stable refraction, as I mentioned, whether age, the type of error. This is also very important. And of course, the refraction will tell you your limitations. Patient who comes with high error or with high myopia or high hyperopia, he should have much less expectations about the postoperative results. We mentioned that the cornea is important to choose the right technique and to choose the right tools to do this. We mentioned about the pupil. The cornea. Nowadays, the cornea, since we are changing the cornea, and since all refractive surgery aims at changing the refraction of the anterior part of the cornea to compensate for the error that he has, so it's very important to study the cornea. We started with only Placido type topography, and now we have the luxury of having OCT combined with topography that will give you more details and can tell you the suspicious cases that you should not operate, and it can be a baseline for future. If the patient comes after 1 year with any complaint, you can compare with his conditions pre-operative and post-operative. Sometimes you can even anticipate the result. Patients with steep corneas behave differently than patients with flat corneas, so also put it in mind when you are dealing with the patient. Okay. Thickness. Since we are dealing with, we are removing tissues from the cornea, it's very important to measure the thickness of the cornea. The old days we used to use ultrasonic pachymetry. Now we have the luxury of having a thickness map And we learned that the change in the thickness of the cornea from the center of the periphery is very important. And sometimes this change will give you a warning that this patient may respond differently, or this patient may be really a keratoconic suspect. So please pay attention not only to the thickness, but to the rate of change of the thickness from the center to the periphery. And this is best done by the tomography and by the OCT. In all cases, you have to remember the Baracare law, that you have to leave part of the cornea that will keep the strength of the cornea. We call it residual stromal thickness. The best is to leave at least 300 microns. So you do your calculations and you change your parameters. You may try to reduce the optical zone in order to reduce the amount of ablation, in order to keep the residual stromal thickness within the safe range. Also, there are now anticipations about comparing the amount of tissue removed to the total corneal thickness. Okay, so this is also part of the options that will allow you to judge your technique and to judge your results, which is called the percentage tissue altered, PTA. This percentage is which is the difference between the amount, or the relation between the thickness that you will remove in relation to the corneal thickness. And there is, for me, 1/3 is the maximum that I can remove. Of course, the corneal biomechanics we heard. Recently, I heard that there are some more instruments that will come into play. Some of them use the light, some of them use the sound. All of them try to check the properties of the cornea and respond to something, and then this something could be a force of air, or a force of light, or a force of even sound. And then by evaluating the response to this stimulus, you can differentiate the types of cornea, as very well illustrated by Mazen, the viscosity and the elasticity of the cornea. This is very, very important. And again, now there are trials to make the surgery customized based on the corneal biomechanics. So you have to keep the corneal biomechanics within the safe range. The Brillion is something that I think it become commercially available very soon. The quality of vision. This is very important. The Snellen chart that we use is not the final result. Many patients can see 20/20 and still complain. Why is that? Because as we learned also about the corneal wavefront, the quality of vision doesn't depend only on the Snellen chart, but it depends on the wavefront analysis and the image, the quality of the image that reaches the retina, the point spread function, the total RMS. All these are parameters that you should be aware of, and you should also study some of it. Something like the contrast sensitivity, the changes between the illumination. Some people who work like night drivers or something may be really handicapped if you don't pay enough attention to their quality of vision. Also, the wavefront now is regaining. You know, it was highly appreciated for a while, then it lost its importance. Now it's gaining, and now we are depending mainly on the ray tracing. The ray tracing, they trace the rays that enter the retina and check it when it comes back, and this gives you the most valuable evaluation of the real corneal front, wavefront. Okay? Dry eye, we spent a lot of time discussing the dry eye, because really the tear film is an integral part of the cornea. It's not just an addition. But now when we ask our undergraduate students what are the layers of the cornea, they have to tell you that the first layer is the tear film, and they know the component of the tear film and study the quality, not only the quantity of the tears. So this is a whole topic by itself. So choosing your patient is very important, because if you're the In English, they say garbage in, garbage out. So if you did not examine your patient properly, you will not choose the proper treatment and you will get unfavorable results. On the contrary, if you choose, examine, it's better to exclude many patients. Now, as you grow older, the percentage of rejection becomes more and more higher, because we learn from our own mistakes. No, try to avoid these patients, because really an unhappy patient will spoil your, on the other hand, a happy patient is very important for any refractive surgery practice. Thank you for listening, and if anybody has any question, we are more than welcome.